like your volume ventilation total control situation. We do this in surgery, we do it for total control afterwards. Awake patients often don't like this setting. So when I worked for Bowers Ambulance, and most of what I did was transporting someone from a hospital that had been there forever. They were taped and pegged and they were on the ventilator, and they're going to like a kindred type of facility, and so they needed a nurse to go with them, and there was no RT, and we had this tiny little box of ventilator, and the only thing that did AC, and these are patients who had been off of AC for a very long time, and they often didn't do well because AC is total control, and so patients who are wide awake don't often, like some people tolerate while awake, but most patients don't love it. So what it does is it gives you a preset number of breaths and a preset tidal volume with every breath. And if you trigger a breath in between on your own, they're going to still get that mandatory tidal volume. The advantage of that is that it really gives you good control of the respiratory function, including better volume ventilation, because the breaths in between could be minimal. But the bad thing is that sometimes the patient will fight the ventilator. There's something called ventilator dysynchrony, where they're not working well with it, and there's not a capitated number of breaths either, so they could breathe at a rate of 40, and it's shoving a high tidal volume in for every breath, so it can be a problem as well. And again, alert patients don't often like this mode. They have the feeling of forced ventilation, and the patient can get really tachycardic, tachypnic and tachycardic as well. So the next step down is SIMV. Now, SIMV stands for IMV is intermittent mandatory ventilation volume, or synchronized intermittent mandatory ventilation volume. So on this patient, it's a little more natural in the breathing. So still volume ventilation, and still it's going to deliver its set breaths at a mandatory tidal volume. So if you have set at 10, it's going to give you those 10 breaths at the tidal volume that you set. But in between, the patient may breathe and have their own rate and tidal volume. It's a much more natural way for them to breathe as well. The advantages, it can be used as a weaning mode, but bad if the flow rates are not well met by the patient needs, the O2 needs might not be met. Sometimes we add pressure support just for that reason. The thing I want to add is back in the day, everybody went from AC to IMV to CPAP. It was like a natural progression. And there's a lot of pulmonologists out there now that are skipping this step. They say if you're well enough to go to IMV, you're well enough to go to CPAP. Not always true. But just so you may not see it as often, but it is a little bit more of a natural way to breathe as well. I'm not going to go over the waveforms again, but they're there for you as well. All right, so pressure support. So this is just allowing you to do all the breathing yourself, but it's going to shove in a certain amount of pressure. So it's going to assist you by giving you more pressure. So it supports your own spontaneous inspiration, so there's no rate set. So you have to have your own ability to create breaths as well. The preset pressure is delivered very rapidly. We do this for weaning. They must have a ventilatory drive. It can be added to IMV, and it can encourage muscle strengthening, and it is dependent upon the patient's respiratory drive. And a lot of times what we sometimes do is we put patients on CPAP during the day when they're awake, and then we put them back on IMV at night. So it's kind of, we're really trying to strength train them to get them better. It doesn't always work, but hopefully it will work as well. All right, so I love the video we saw because I think it explains PEEP better than I ever could. Positive index blood pressure, and it explains why we drop blood pressure in PEEP so commonly. We really have to watch this as well. So it's similar to blowing up a balloon and not letting it completely deflate but blowing up again. Most patients are started on 5. Some patients with those with Ards or other conditions require higher levels of PEEP to keep the alveolus from collapsing and to decrease the intrapulmonary shunting. So those bad alveoluses, whatever reason, they're surfactant or filled up. It's not unusual to see 8 to 12, but PEEP should usually not exceed 20 unless we're doing the super PEEP thing. Higher settings increase the risk of severe lung damage, subcutaneous emphysema, and pneumothorax as they blow out bloods, especially on your COPD or steroid-using patients as well. Okay, challenging to ventilation in ARDS patients. So the lungs are very non-compliant and inelastic, and so being able to get the volume in there is very, very hard. So poor compliance equals smaller tidal volumes and poor ventilation for these patients ventilation means hypercapnia and acidosis. More acidosis decreases muscle work. And for normal ventilation, we have to give them higher volumes. Higher volumes can lead to barotrauma, and you can also have severe hypoxia. And high O2 can lead to O2 toxicity. Never seen that in my entire life. Let me turn my phone off. But have you seen O2 toxicity?
Only on COPD.
Only on COPD patients. Yeah, because they stop breathing. Okay, well I have seen it. I just never thought about it in that way. So thank you. Okay, let's look at this. Right here. Let's see which one this is. Yep, it says good review, so we're gonna watch it. It's 3 minutes. It's worth our time.
Some of the patients you will encounter may develop acute respiratory distress syndrome, also known as ARDS. In ARDS, the affected part of the lung is not the airways. Rather, the affected part of the lung is at the alveolar level. ARDS is caused by leaking of fluids into the tiny alveolar sacs of the lungs. So, for example, here is one magnified alveolus. And normally, oxygen that is inhaled into the alveolus is supposed to diffuse into the blood so that the blood can deliver the oxygen to the body. But in ARDS, fluids fill the air sac. The integrity of some of the alveoli will be compromised, often leading to alveolar collapse or atelectasis, and this will ultimately compromise gas exchange. So as a result of diffuse alveolar collapse, the lung will appear to shrink on a chest X-ray film. Collapsed alveoli may also result in refractory hypoxemia. Refractory hypoxemia is hypoxemia that does not correct with the administration of supplemental oxygen. In other words, you can try to administer high levels of FiO2, but because the alveolus is collapsed and compromised, oxygen concentration alone will not correct the hypoxemia. Correcting refractory hypoxemia will require a recruitment of the alveolus, which is a reopening or a restabilizing of the collapsed alveolus. The oxygenation status of the patient is also one of the ways in which we classify the severity of ARDS. So to determine the oxygenation status, the clinician should perform the PF ratio, which is simply the PaO2 divided by the FiO2 of the patient. Here you can see the classification of the severity of ARDS, as well as the mortality risk. So improving oxygenation will be one of the challenges in treating ARDS. But how can we get oxygen in if patients with ARDS have a difficult time getting volume into their lungs due to the fact that the alveoli are collapsed? Reopening collapsed alveoli will require an immense amount of patient effort. Additionally, the lung will tend to recoil upon inhalation. In other words, even if the patient does inhale volume, the lung will immediately want to recoil and exhale. This ultimately leads to shallow and rapid breathing. So that begs the question, what are some strategies in modifying our ventilator settings and treating patients with ARDS? And the answer to this question is coming up in the next lessons. So stay tuned.
So I hope you liked this video.